we described a whole new family of technologies that would make possible to collect data about an individual patient and transform into a computer simulation able to predict the risk of having a bone fracture in osteoporotic patient for the next 10 years. It's extremely challenging because most of the fragile elder experience low energy bone fracture, so fracture associated to event that normally would not break a bone in a normal healthy adult, for two reasons. The first, because of skeletal fragility. Diseases like osteoporosis tend to make our bones weaker. But there is a second fundamental reason. There's a whole set of factors that has to do with the weakening of the muscle, the loss of neuromuscular control, the loss of visual or auditory acuity, that tend to increase significantly in the elders the probability to fall or even just to overload our skeleton while we're doing normal daily activity. So this combination makes the whole thing extremely difficult. Yes, in order to be able to predict the risk for a given patient, the personalized risk with a good level of predictive accuracy, we need to account all of the factors that have to do with the neuromuscular control. So we have to describe the entire body of the patient. We need to describe the strength of the bone, so at the scale of a organ, but we also need to describe the process that happened at the cellular and tissue scale, so at the microscopic scale, that eventually over time, because of the disease or because of the pharmacological treatment, will alter the strength of the bone, changing the scenario. I'm the director of an institute that looks at in silico medicine in all diseases. So even if my own research is in musculoskeletal, I work with cardiovascular and neuroscientists, etc. And I noticed that the perception of this determinant is very different in different healthcare sectors. Musculoskeletal medicine is very cost conscious, which is good because in this economical climate, it makes us probably more resilient than other. But I think that we not always consider the total cost of care. What I mean is, if one elder has a femoral neck fracture, that event will cost a primary care £20,000 or 20,000 euro or whatever is the currency. Okay? To this, we have to add the secondary care, which is rehabilitation, care for the elder who is not self-sufficient, and so on. So, if we can avoid even only a few of those, the total cost of care would be very, very positive. So the cost is all relative, I think. They're extremely accurate. The best clinical cohort we investigated to date, which made available all the detailed data that we require for this type of examination, achieved a predictive accuracy close to 90%. The real problem is that those data are very difficult to obtain in the traditional clinical process. So we need to work on two directions. One, we need to find a way to maintain the same accuracy with less complicated data to get. Okay, simplify the constraint on the clinical application. The other is to convince that it's worth to spend a little bit more and get better data because it comes back. That's what I was saying before about the total cost of care. I think one of the beauty of in silico technologies is that they can become completely invisible. I'm sure you use a GPS every day. You have no idea how it works. It's horribly complicated, but it's being packaged in a way that you don't need to know how it works in order to use it. And this applies very much. So it wouldn't be very different from instruments that today are used, like the FRAX interface. You select your patient, automatically the system query the hospital database for whatever data are necessary, and then something happens behind the scene, which is very complicated, but it's invisible, and you get your risk estimator. So from a clinical point of view, it wouldn't be very disruptive. No, absolutely. As I said, I have the honor to lead this new institute in Sheffield called the Insignio Institute for In Silico Medicine, where we apply this approach to virtually any disease. Currently, we have running projects in rheumatoid arthritis in children, in gynecology, in Alzheimer, and name it.
Very exciting.
We're talking about goal-directed treatment for osteoporosis, which is a change from the way we do things standardly in clinical practice. People have been happy if a patient has been responding. By that, we mean if their bone density goes up some, well, at least if it doesn't go down, and they don't have a fracture, you are happy and the patient is happy. However, if their risk is high and their bone density is very low, I'm not happy. And those who would be treating towards goals are not happy. You can respond, that's important, but even if you respond, it may not be good enough. Well, the best goal, we believe, would be reduction in the risk of fractures to some low level that we're happy with. And so I think that ultimately, we hope that we put our goals in terms of risk, lowering your risk. We'll never be able to bring risk to zero, but we'd like to, I think, doctors to focus on lower risk. The problem with that right now is that we just don't know how to do that. We don't know of and don't have good tools for telling a patient or a doctor what that patient's risk is while they're on treatment. And because we don't have those tools, the next best tool is achieving a bone density that we know is reasonable. A bone density that means that if you're above it, you're at high, and below it, you're, the other way, above that bone density, you're better off, and at a lower bone density, you have a very high risk. -2.5 seems to do that. If a patient doesn't adhere to treatment, they're not going to either respond or achieve a goal. And so, yes, it's a foundation. I think in all treatment for osteoporosis and for any other condition, adherence is the foundation, and it's also a big problem. We know that most of the patients that we recommend treatment for are not taking them a year later. And so our recommendation is that you try to estimate how much the adherence is off, how much you've got. And that if it's less than 80% adherence, then we know that your fracture risk is not optimally suppressed. And so if it's less than 80%, we recommend the doctors have the patients visit about compliance or adherence, maybe talk to the nurse, maybe a reminder phone call, good education. Try all of those things, and if adherence is still poor, there are medications that can be given as injections, and twice a year or once a year that guarantee adherence. So poor adherence, you're not going to get to your goal, you're not going to respond. If they should be treated, then they should be treated with a parenteral agent. We need stronger therapies. Right now, it's frustrating to a patient to set a goal and then have no way of reaching it. And we know our bisphosphonates are not a very effective way of reaching goals for patients who have severe conditions. So there are treatments in the wings, vodanicatinib, anti-sclerostin antibodies that look as though they will be better tools for doctors and patients to reach the goal. So assuming that they are approved and are in use, those will be very important tools. But this field, unlike others, diabetes, cholesterol, hypertension, where there is a lot of research comparing one strategy to the other, one drug to another, we don't have that much in our field. And so I'm hoping that by pointing out the need for trials about treatment strategies, like, is this goal better than that goal? We'd love to have randomized trials comparing this to that goal, this to that way of managing. Those will be expensive, and I hope that they come. And I think that's the other greatest need. if a drug is not working adequately during follow-up, then you'd like to switch to something stronger. Well, the studies we've got about how much better you do with a switch, there are not very many of them, and they don't last very long. For example, I think there's a 1-year study for switching to denosumab and an 18-month study for switching from alendronate to teriparatide. That's not much data. And in both cases, the results were not very impressive. For example, hip BMD in the first, denosumab, improved only 1%. And with teriparatide, the improvements in spine bone density were around 5 to 9%. However, very little improvement in hip bone density, 0 to 2%. So what we know about switching is very limited, short-term studies, just a couple of drugs. It's a big hole that needs to be filled now that patients have been on treatments for so long. Well, the next step is building consensus. We've got recommendations. We need more people to see them, comment on them, refine them, and I'm hoping that we will have recommendations as of the 3rd or 4th quarter this coming year. And I'm sure that those recommendations will make some people angry, and some people will criticize the lack of evidence, and I'm hoping that that starts another debate, but mostly starts a series of studies that will improve what we publish this year. The most important message is consider a goal when you're starting patients on treatment, and keep that goal in mind as you follow them up.
I'm Bente Langdal, past president of ECTS and professor of endocrinology.
Yeah, my name is Klaus Glühr. I'm the brand new president of ECTS, and so we are here to discuss what is actually the final session here that we have been watching together.
Yeah.
And I think we are both excited to see a view into the future.
Yeah.
We have to bring it about. That's not quite there, but maybe I can start by bringing the essence of Marco Viceconti's presentation. He was involved with this virtual human in the osteoporosis area, and this was a big European project with 20 centers involved. And I think the strength of this project is that they try to bring together a whole lot of different perspectives on how to assess the body from the organ level to tissue level down to the cell level, because eventually you need to evaluate all of these individually, and then also establish the links, how the cells communicate together, and then to the tissue level and all the way up to the organ level. And ultimately, of course, in our setting, strength of bone, fragility, and I think my interpretation is we are not quite there yet. No. We saw the estimates of the computing time, and still in 3-4 years it will still be quite significant. But it's the concept, I think, that is here quite convincing. And so we have to work on the components further to bring about the whole thing.
Yeah, and I agree. And you know, as a clinician, you know, in day-to-day life, we are stuck with age, previous fracture, and the BMD, and we can try to use FRAX, or we can use something else, and we still know there's a huge variation of the estimates we get out of that. So if things could be done, where we could have like a better estimate, then we would be able to make better evaluations of the patients. Do they need treatment? What kind of treatment maybe do they need? So I think it's quite interesting. But as you said, I'm also quite certain that it's not just around the corner as a tool we'll have available.
As we saw here at the meeting, I mean, we will now have first prospective studies, at least for vertebral fractures, showing that the QCT or finite element assessment is better than the clinical DEXA. At the hip, we are getting there, not quite there, numerically better, not statistically. But I think that was good news.
Yeah, yeah, fascinating. And actually, I think it was a very good introduction to the second talk, or you can say you need the first thing before you can have the second
Yes.
thing, because
Yes.
the second talk was all about, having better aims for treatment. That would be a goal for treatment. But of course, the difficult thing, as also Professor Steve Cummings highlighted, was actually, first of all, to agree on what is actually the right goal, what is the right target to aim for, but it's interesting to listen to the thoughts behind, should it be BMD, should it be absolute risk, should it be markers, what should actually, or a combination maybe. So I think so to me that was kind of taking it one step further.
Having a goal, I think, is certainly a good strategy. But as you said, we need to have a valid surrogate marker that captures how we are doing, how far we are from the goal, and if we are improving, are we improving? And as mentioned by Steve, and also by the people who ask questions, there is discrepancy between BMD change over time and the reduction in fracture risk, which indicates that there is a limit to BMD in the interpretation. And maybe markers in that setting might be better. Do you think so? Or what's your
I think maybe
experience
what the markers will be best for is actually maybe monitoring adherence, because I think they're probably the most sensitive we had, at least at the moment, when we can't measure the drug in the blood or something. They are probably the most sensitive markers of adherence or response together. So maybe they could come in with that aspect to kind of help us understand if the patient is taking the drug or if the drug works in this patient for one reason or another.
And that's absolutely key. I mean, if we're talking chronic disease, we mentioned this in the discussion of the other symposium, we need to make sure that the patients are motivated to take their drugs over many years. And
but at least I think that might also help, because I have experienced, since we started discussing treatment holidays with the patients, that some patients get more motivated when you tell them, so this might be for a 5-year period or a limited number of years, whereas just few years back we told everybody this were for the rest of your life, and it was just you could see some patients, they were the rest of my life, whereas 5 years, it may sound long, but it's still a limited number of years. So maybe the same thing could go for the target if we explain to the patient, so you need to reach this bone mineral density, or you need to have this and this increase in bone mineral density, or reduction in your risk, and then we can start considering doing something else, or maybe doing nothing at all. So I think it might be easier for the patients to understand what is the purpose of the treatment.
And the concept, or the fine-tuning of this concept, I think comes at a good time, because unlike in the past where, you could say, well, I have a goal, I'm this far or this far away, but you didn't have different treatment options really available. It has already changed and will change much more with the upcoming new drugs that we see. And only then, if you really have a choice, depending on your assessment how far you're from the goal, then the concept can make sense.
No, it's actually it's going to be fascinating to treat osteoporosis again, because you probably will have different choices. Of course, we need to convince the authorities that they should allow us to use different treatment options in different patients, and not always force every physician to use the same drug in any patient. But that could be a very good opportunity, I think.
But there we are perfectly aligned with the current concept of personalized medicine. I think with the treatment options and with a refined diagnostic assessment, where depending on whether it's a primary or a secondary osteoporosis, you may want to include different treatment, different diagnostic methods, then you really can come forward with a personalized concept.